It's a pleasure to have all of you in this ongoing Apna Merit Hematology Oncology webinar series. I would like to introduce our speaker today. Dr. Azka Ali is a breast and phase 1 medical oncologist at Cleveland Clinic Cancer Center and an assistant professor is at Case Western Reserve University. Her areas of interest include novel mechanisms of resistance and developmental therapeutics in metastatic breast cancer. She obtained her MD from the Medical University of South Carolina and did her internal medicine residency, chief year, and fellowship at the University of Florida in Gainesville. It's a pleasure to have her as a speaker, and I hope that you will enjoy this particular session. Dr. Ali, the floor is yours.
Thank you very much for that kind introduction. Make sure there's hopefully no more further technological issues. Okay, everybody can see this, right?
Yes.
Okay, very good. Thank you so much for the kind invitation. Let me make sure I can make that disappear. Okay.
Yes, we can see the screen now.
Okay, thank you. All right, thank you, Dr. Osmani, for that introduction. Like you said, my name is Azka Ali, and today I'll be talking about management of metastatic hormone receptor positive, HER2 negative breast cancer. These are my disclosures. So this is the agenda today. I would like to talk about first-line endocrine therapy treatment, what's beyond first-line endocrine therapy, beyond CDK4/6 inhibitor treatment. And there's actually a part 2 that we will be coming up with in a few months here and really focusing in on where are we with antibody drug conjugates. So first, what do we have in terms of endocrine therapy treatment? In terms of metastatic recurrence, as we all know, biopsy is key. ER/PR HER2 profile can change in up to 20% of patients. HER2 status is no longer positive or negative, so now HER2 low, and now we have additional categories of HER2 low, which is HER2 IHC 1+ or 2+ with a negative FISH, or an even newer category, ultra low, which is less than or equal to 10% membrane staining. NGS is obviously very important and really important to do that at the time of progression. I think one question that keeps coming up, at least where I practice in our tumor board, is what's the role of surgery for oligometastatic disease? In 2108, that it does not improve survival, but it can help with local control issues. Other kind of pearls that I want to mention here before we get into the endocrine therapy, if patients are premenopausal, we must suppress their ovaries or remove ovaries for best outcomes. For HR positive disease, we have to prioritize endocrine-based therapy over chemotherapy. Of course, we're talking about metastatic breast cancer here. We have seen better response rate, better duration of response, even in visceral crisis in the right choice trial. If bone mets are present, we have to add bisphosphonates or denosumab to our treatment plans. So here's a general schema of treating HR positive, HER2 negative metastatic breast cancer. We can see that this is a breast tumor cell, which is treatment naive. With endocrine therapy through selective pressure of treatment, that cell goes through a lot of changes. And a lot of changes, then come up with, lead to a lot of genomic alterations. Some of them, like PIK3CA, are truncal, which means they're present at the beginning of the cancer development. And some of them will develop with time, like ESR1 mutation. I really like the schema here because I feel like treating HR positive breast cancer is getting increasingly complicated. So this little schema here, I think, really breaks down what are the key points in that breast cancer resistant progression and what are the key points that we need to block. So for example, the breast cancer really depends on this PI3K pathway, which leads to AKT mTOR, and then kind of like this cell cycle transcription translation mediated by cyclin D1 CDK4/6. So that PI3K being such an important checkpoint, alpelisib or capivasertib is a pathway inhibitor in this space. We've obviously had mTOR for many years, mTOR inhibitor in form of everolimus. Cyclin D1 CDK4 is a major checkpoint, so we have CDK4/6 inhibitors in this space that block this space. And then kind of our more traditional historical endocrine therapy, which is the direct blockade via aromatase inhibitors at the level of estrogen or blockade at the level of estrogen receptor. which could be done with tamoxifen, which is a SERM, selective estrogen receptor modulator, or fulvestrant, which is a selective estrogen receptor degrader. So this pathway is complicated even for me, so I decided to kind of break down that schema and talk about one checkpoint at a time. So in terms of first-line therapy, we have endocrine therapy plus CDK4/6 inhibitors. These are the cell cycle arrest biologics, and they are very, very important. So just to review once again, what do we have in terms of endocrine therapy? We've got the SERMs, tamoxifen, tamoxifen, estrogens, SERDs, fulvestrant, and the newly approved elacestrant, aromatase inhibitors in form of anastrozole, letrozole, like exemestane, progestins, probably dated now, androgens, also not clinically used very much. And then we have three CDK4/6 inhibitors. We have palbociclib, ribociclib, abemaciclib. All the trials that feature Palbo are the Paloma trials. All the trials that feature Ribo are the Mona Lisa trials. And all the trials that feature Abema are the Monarch trials. So this is the phase 3 frontline CDK4/6 inhibitor studies. And I like this picture for a direct comparison, which we're not supposed to do in oncology, but it helps you understand how the trials were designed, what patients they enrolled, how patients randomized, and what was the control arm. So Paloma 2 is the frontline palbociclib study, which took 666 postmenopausal women with HR positive, HER2 negative advanced breast cancer. This trial did 2-to-1 randomization, and the randomized arms were palbo letrozole versus placebo letrozole. Primary endpoint you'll notice in all these studies is progression-free survival. Mona Lisa 2, Mona Lisa, like I said, those are the Ribo studies. That took 668 postmenopausal patients, HR positive, HER2 negative. You'll notice Mona Lisa studies, they did 1-to-1 randomization. So this is 1-to-1 randomization to Ribo letrozole versus placebo letrozole. Once again, PFS is the primary endpoint. Monarch studies are the Abema studies. This took 493 postmenopausal patients, HR positive, HER2 negative. This is also a 2-to-1 randomization, Abema plus a non-steroidal aromatase inhibitor versus placebo and a non-steroidal aromatase inhibitor, primary endpoint PFS. Mona Lisa 7, this is the pre-perimenopausal study, huge study, over 600 women, HR positive, HER2 negative, 1-to-1 randomization, Ribo plus TAM, NSAI. Obviously implied here is the use of ovarian suppression because they were all pre or perimenopausal women, random versus placebo, TAM, NSAI with the ovarian suppression, once again with the primary endpoint of PFS. So this is a Paloma study, Paloma 2 study, first-line palbociclib study. These were metastatic patients, post-menopausal, randomized to letrozole placebo versus letrozole palbociclib. 2-to-1 randomization, we can see 404 patients in this arm, 222 patients in this arm, and we actually get a teaser to the results. There's an improvement in progression-free survival, which was the primary endpoint, from 14 months to 24.8 months. Here are the results. The top purple line is the palbociclib letrozole arm, and the bottom red line is the placebo letrozole arm. And the primary endpoint, we had an improvement of PFS 14.5 months to 24.4 months. This is the overall survival that I would say has and remained very controversial, because when this was reported for the first time in 2022 at this point, the overall survival was not met. So you look at the study, and this is obviously the first drug that we had used, first drug that came out in the market, and we had been many patients that had put on this drug derived a lot of benefit, and the study comes out, and the overall survival is essentially significantly similar. Mona Lisa 2 study, this is the Ribo, first-line Ribo study in the postmenopausal patients, HR positive, HER2 negative, 1-to-1 randomization. Significant PFS and OFS improvement. So you'll see the purple line up here is the Ribo probability of PFS, and the bottom line is the overall survival. Here you'll see the improvement is 51 months to 63 months. I showed you with Palbo, the Paloma 2 study was like the 51 to 53 month difference. Mona Lisa 3, this is first or second line Ribo. So these were patients randomized 2-to-1 to receive Ribo fulvestrant or placebo fulvestrant. In first or second line patients, they were obviously, some of them were stratified, especially the second and the first line patients. And in terms of results, the top line here is the Ribo fulvestrant compared to placebo fulvestrant. We see the PFS is statistically improved, but it has a ratio of 0.59, a significant p-value of 0.001. And then we see in the overall survival, this is also significant, with a 40-month overall survival at the time of report in an unreached overall survival in the ribo fulvestrant arm. So MONALEESA 7, this is the first-line ribo study in the premenopausal patients that I mentioned. Really great study, took over 600 women, assigned 1-to-1 to receive ribo plus a non-steroidal aromatase inhibitor or tamoxifen plus goserelin versus placebo plus non-steroidal aromatase inhibitor or tamoxifen plus goserelin. Significant improvement in PFS here, as you see in the ribo group, as well as a significant improvement in overall survival. You'll notice here, younger patients, much higher risk disease, so the overall survival numbers don't look as good as the postmenopausal numbers that I showed you, but still quite a significant advantage from 48 months to 58.7 months. Monarch 3, this is the first-line ABEMA study. These were postmenopausal women, HR positive, HER2 negative, advanced breast cancer, no previous systemic therapy. This is a slightly smaller study. This is a 2-to-1 randomization. Patients received, like I said, ABEMA letrozole versus placebo letrozole. Once again, the primary endpoint is progression-free survival. We see an improvement in terms of PFS that is significant, and we also see an improvement in terms of overall survival here. Interestingly, the hazard ratio here is 0.8. You see the confidence interval crosses 1, and the p-value barely misses the mark. Now, the interesting thing here is you will notice in terms of the follow-up, the Monarch 3 study had a much longer follow-up. So if you look in time, in a number of years, this is close to 8 years. And some of the ribo, the MONALEESA studies I showed you, they could do their final OS analysis at 6 years. So if we had done the analysis at 6 years, it was going to meet its overall survival endpoint. But because of the way the study was designed, they had to go all the way out to 8 years to meet the overall survival events. Those were intended, and perhaps with longer follow-up, the overall survival endpoint was best. So where are we in terms of all these studies? I know they're incredibly similar in a lot of ways. So once again, to summarize, Paloma 1, I didn't discuss that today. Paloma 2, we talked about. That's the first-line Palbo study. MONALEESA 2, we didn't talk about. MONALEESA 2, I showed you. Monarch 3, I showed you. And then MONALEESA 3 and MONALEESA 7, we talked about. MONALEESA 7 being the pre-perimenopausal study. What we notice here is the primary endpoint. For all of these studies, it is progression-free survival, and they all meet their primary endpoint. And progression-free survival is in a range from 9 to 15 months, depending on the type of the study. And so that is significant for all of them. Overall survival is met in the ribociclib studies, as you can see, MONALEESA 2, 3, and 7, with a hazard ratio of a confidence interval that doesn't cross 1 and a significant p-value. I think what I would say is the primary endpoint was PFS, so I think we should still feel confident using them, but the overall survival issue does raise the concern. Toxicity considerations, hopefully no big surprises here for those of us who use these drugs. Palbociclib is given on a 21-day cycle, in a 21-day duration on a 28-day cycle. So it's 3 weeks on, 1 week off. Similarly, ribociclib is the same way. It's given 3 weeks on, 1 week off. ABEMA is the only drug that has a continuous dosing. It's 1 pill twice a day. In terms of side effects, a lot more neutropenia with palbociclib and ribociclib. I would say a lot less in abemaciclib, but we do see it. I would mention, though, febrile neutropenia overall is very low. So I feel in these patients, when they show up and ANC is 900, even though the package insert says, they need to be above 1,000 to continue. I've many times let them, continue with an ANC of 900 because we just don't see the degree of febrile neutropenia that we see with cytotoxic chemotherapy. In terms of diarrhea, hardly any diarrhea with palbo, some with ribo, a lot more with abema. I would say this is a pain in the back and a very tough side effect to manage. Creatinine elevation, I would say I do see that with ribo as well, but more so with abema. It is not an impact on GFR. It is a creatinine clearance. It's a competition with the creatinine clearance. So we see the mild rise in the numbers. LFT elevation, per package insert, you can see both with ribo and abema. I can tell you clinically, I see it a lot more with ribo. It can get pretty high and takes forever to resolve, 4 to 6 weeks. Sometimes we have to hold the drug. QT prolongation, this one's interesting. A lot of these side effects are class effect side effects, but ribo is the only one we do the QT interval monitoring for. Probably happens with the BEMA, we just never look. Pneumonitis, this is an important side effect that actually came into awareness with a lot of the post-marketing data. So it's a very, very rare risk, 1 to 2%. It's inflammatory in nature, so we must treat with steroids and stop the drug. And if patients are complaining of cough, we should be doing x-rays and CT scans to look for this. Here, so subgroup, this is very interesting. When we break down these studies, are there any subgroups that are going to benefit from the CDK4 inhibitor incorporation, or are there any patients that can do well with endocrine therapy, like an aromatase inhibitor or fulvestrant monotherapy alone? If you look down here, whether your patients are PR negative, disease-free interval that's short, disease-free interval that's long, de novo metastatic patients, whether they're lobular, whether they are bone only, whether they have lung or liver mets, whether they're younger than 40 or older, everybody benefits from combination. So right now in 2025, we should be offering combination therapy with an aromatase inhibitor or fulvestrant with a CDK4/6. It looks like hands down is better than placebo, which is AI or fulvestrant monotherapy. What about second line treatment trials? So I would say second line space is very, very competitive. I think it's up for grabs. It remains up for grabs. We have, before we get into that, what do we do with CDK4/6 in the second line? So these would be patients that for whatever reason got a monotherapy in the first line. Maybe they were older, maybe they didn't have access to it. Could you come back in the second line with fulvestrant and use it? And is there still benefit? It looks like even if you give CDK4/6 in the second line, it's still very helpful. So if you get a patient on aromatase inhibitor alone, fulvestrant alone, they've progressed, and you want to use that CDK4, we should use it. PFS delta here, 6 months improvement from MONALEESA 3, 8-month improvement in MONARCH 2, and 5-month improvement in PALOMA 3. This is first-line triplet in INAVO 120. So this is for the first time, we now have some data for a triplet combination. Honestly, it gives me a lot of anxiety in terms of toxicity because PI3K inhibitor drugs that we will shortly discuss, they do have a lot of toxicities and they're tough to manage, but here's the trial. So these patients, what I like about the inclusion here is that these patients patient population is enriched for poor risk patients. So these are PIK3CA mutated patients, HR positive, HER2 negative, measurable disease, but they've had a progression either on adjuvant endocrine therapy or those that were that had finished their adjuvant endocrine therapy within the last 12 months. So they're high risk patients. They're quick relapsers and quick recurrences. No prior therapy for advanced breast cancer, and the fasting glucose had to be less than 126 with a hemoglobin A1C of less than 6%. They did stratify patients based on visceral disease, endocrine resistance, whether that was primary, secondary, and the region where the patients were enrolled from. Patients were randomized 1-to-1 to receive inavolisib, which is a PIK3CA inhibitor, palbociclib, fulvestrant versus placebo, palbociclib, fulvestrant. Patients were continued until progressive disease or toxicity. Primary endpoint was PFS by investigator. Secondary endpoint was overall survival, response rate, duration of response, clinical benefit rate, and PROs. So here's the data. You see an improvement with incorporation of INAVO. So once again, this is a triplet therapy. So INAVO, palbo, and fulvestrant versus placebo, which would be your standard palbo fulvestrant. Now we can look at the data and say, well, based on the data you showed us, with palbo, should palbo have been the comparator? Well, that's just how, the trial was designed. This is, these trials have enrolled for years and years, and palbo was the first drug on the market. So that's how they made the cut for this trial. In terms of overall survival, this data is extremely mature. Obviously, it looks like there's a trend towards survival, but we haven't seen a lot of these patients yet, and we're just at 42 months. So FDA in the US has approved inavolisib as of a few months ago with palbo and fulvestrant in endocrine resistant. Once again defined, which in my practice, I'm defining it the way they define it in the trial. So if you progress on adjuvant endocrine, or if you completed adjuvant endocrine in the last 12 months, PIK3CA mutated, HR positive, HER2 negative advanced breast cancer. So what is going on in the second line? This space is getting very tight. We will work through some of the data. So we just finished talking about the CDK4/6 inhibitor. An important target over here is actually the estrogen receptor itself, right? So we've got tamoxifen, which is the modulator, then we have fulvestrant, and now we have a newly approved SERD, at least in the US, elacestrant. So what do we know about selective estrogen receptor degraders? Fulvestrant has been around for several years, first approved SERD in 2002. It induces proteasomal degradation of the ER in a dose-dependent manner, longer duration of action, modest PFS, I would say as a monotherapy, 2 to 4 months, minimal efficacy after CDK4/6 inhibitors, which has really raised the question in the last several years, is it even a good second-line monotherapy option? Should we be adding something to it? So what are ESR1 mutations? This is one of the main mechanisms of resistance to aromatase inhibitor therapy. 20 to 40% of patients that are HR positive metastatic breast cancer with prior aromatase inhibitors are going to develop ESR1 mutations. Essentially, what it is that receptor will mutate and it's rendered permanently active. So what a SERD or a oral or a sub-Q SERD would do, it would come and permanently degrade that receptor, which is why when we biopsy after fulvestrant, those tumors are going to be ER negative because that ER has been completely degraded. This does portend a more aggressive disease, worse prognosis if there's ESR1 mutation present. So Emerald phase 3 trial was reported several years ago. This is the trial of elacestrant, which is an oral SERD versus standard of care endocrine therapy in patients with ER positive HER2 negative metastatic breast cancer. So this is an interesting table. This puts together all the SERDs that we have and talks and shares the pros and the cons of different trials and the limitations of different trials. So Emerald is the one that I will briefly discuss. This featured elacestrant. Serena-2 has been reported in the past. This used camizestrant. Ember-3 has now been reported as of SABCS 2024. This featured imlunestrant. Amira-3 used emnacestrant, and Accelera used giredestrant. So focusing in on Emerald versus some of the other studies, this is a phase 3. This required 100% prior CDK4/6 usage, which I think is the strength of this study because it represents a very realistic real-world population. This also allowed prior fulvestrant use, which again, I think it represents a really realistic population. Prior chemotherapy was allowed. I will show you the data shortly. Not a lot of patients had prior chemotherapy, but it was allowed. And what we saw in the results is that there was a PFS improvement, particularly in the ESR1 mutated patients. This is to date the only oral oral SERD approved by the FDA. So here's the design. This included men and postmenopausal women with advanced metastatic breast cancer. Patients were ER positive, HER2 negative. Patients that progressed or relapsed on or after 1 or 2 lines of endocrine therapy for advanced disease, 1 or less line of chemotherapy for advanced disease, ECOG performance status 0 to 1. These are the stratification factors. Patients were randomized 1-to-1 to elacestrant and investigator's choice of endocrine therapy. Fulvestrant's there, aromatase inhibitors are there, and the primary endpoint is this was actually a co-primary endpoint study, PFS in all comers and PFS in ESR1 mutated patients. So here are the baseline characteristics. What I want to call out here is that it took men and postmenopausal women. Visceral metastases were included. In fact, 70% of patients had visceral metastases, 100% prior CDK4/6 inhibitor usage, and prior fulvestrant was allowed. In fact, 30% of patients had prior fulvestrant. Chemotherapy was allowed, although 75% of patients were chemotherapy naive, and those that did have chemotherapy, the 25% of patients, they had 1 line. Here are the results. As you can see up in the blue arm here, there is an improvement in favor of elacestrant compared to standard of care. Please note the early drop-off here. This likely represents a primary endocrine resistant population. The p-value is significant here. This is the PFS in those that had an ESR1 mutation that is also improved. You can appreciate the improvement is much bigger in this group that have an ESR1 mutation versus the all-comers. This is elacestrant compared particularly to fulvestrant because I showed you that was one of the options. And this is actually very helpful and exciting that if you have an ESR1 mutation, and you've got two options. First of all, in all comers, elacestrant looks better. If you have an ESR1 mutation, elacestrant is actually better than fulvestrant. Once again, note the early drop-off. So this is very interesting work. And I think since this work, now we're considering that time, the duration of CDK4/6 inhibitor in the first line, we're now almost considering it as a surrogate marker for endocrine sensitivity. So this was initially presented by Dr. Kaklamani in 2022 at SABCS. And essentially what the investigators did here, they stratified the PFS outcomes by the duration of CDK4/6 inhibitor in the first line. So for example, if you were on CDK4/6 inhibitor in the prior line for 6 months, your benefit was not that big. If you were on it for 12 months, you got much bigger benefit. And if you were on it for 18 months, those are the patients that derived the greatest benefit. And where the benefit gets really interesting is that 18 months, the PFS rate is like 5 times more, from 4% to 21%. So this is very interesting work. So Emerald, once again, is the only phase 3 oral SERD trial with 100% prior CDK4/6 inhibitor usage. Duration of CDK4/6 inhibitor was associated with PFS in the Emerald trial. Longer duration of prior CDK4/6 inhibitor correlated with longer PFS, which means that that duration on that prior CDK4/6 can be a surrogate marker. So if you have somebody on CDK4/6 that's progressing at their 3-month scan, even though they have an ESR1 mutation, if they have a lot of disease, I'm not sure if this is the right option for them if you're worried about them having a quick progression. Among patients with ESR1 mutations, if they had at least 12 months of prior CDK4/6 inhibitor, PFS improved from 2 months, standard of care arm, to 8.6 months. So I showed you the data in all comers where there was an improvement. So you might wonder, why is it not approved in everybody? Why is it approved for the ESR1 mutation patients? And that's because when the data was split up by ESR1 wild type patients, there was no benefit. So the conclusion was that all that benefit in the intention to treat population was pushed by the ESR1 mutant patients. So it's only approved for those that have an ESR1 mutation. So they're moving on forward. So we talked about the CDK4/6 inhibitors. We talked about briefly fulvestrant, primarily elacestrant, because that's, I would say, newer data. Let's talk a little bit about this pathway, which is very interesting. That's the PI3K, AKT, and now I would say even the PTEN. This is the PI3K pathway alteration mutations, for which we've had alpelisib approved for several years, and now we have capi approved for the last 2 years. So PI3K pathway inhibitors, there are 3 FDA-approved agents. There's alpelisib that was studied in SOLAR-1, and then the BYLieve study. There's capivasertib that was studied in CAPItello 291, and there was inavolisib that I just discussed. That's the first-line triplet per Inavo 120, approved in a very specific indication. So not approved in the second line, approved in the first line. So what do we know about PIK3CA mutations? These are found in 40% of HR-positive, HER2-negative metastatic breast cancer. These can be found on ctDNA or tumor tissue, and if ctDNA is negative, we should test the tissue. It's most commonly a truncal mutation, which means that this would be present even at the time of biopsy, but this could be acquired in a small number of patients, so we should be doing repeat testing to identify it. So endocrine resistance, AKT pathway alterations, these can occur in many patients. I showed you 40% of patients can have the PIK3CA mutations. Interestingly, another 5% can have the AKT mutations, and 5% can have PTEN mutations, which means that like half of our patients with metastatic breast cancer can have a pathway alteration in this path, and now we have a drug for it. So we must be testing for this. So CAPItello 291, this was reported a few years ago. These were patients with HR-positive, HER2-negative advanced breast cancer, men and pre-post-menopausal women, recurrence and progression while on or less than 12 months from adjuvant AI, 2 or less prior endocrine therapy lines for advanced breast cancer, 1 or less chemotherapy line, prior CDK4/6 inhibitor was allowed. At least 51% of patients were required to have it. They could not have a prior SERD, mTOR inhibitor, or a PI3K or an AKT inhibitor. Notice that the hemoglobin A1C here threshold was higher. This was less than 8%. In Inavo 120, I showed you the threshold was less than 6%. And SOLAR-1, which we won't have time to go through today, had a threshold of 6.4%. So this is more liberal in terms of what it allows patients to be at with their hemoglobin A1C. Patients were randomized 1-to-1 to capi fulvestrant versus placebo fulvestrant. Notice that this is given on an interrupted dosing. So patients take it for 4 days on, 3 days off, and that's probably why the hyperglycemia is favorable. That I'll show you in a few minutes. The stratification factors, like most of the trials I've shown you, were liver mets, prior usage, and region of the patients. Dual primary endpoints were overall PFS, like in all comers, AKT pathway altered tumors PFS, and these were the key secondary endpoints: overall survival and objective response. So some of the things I want to call out in the baseline characteristics: a total of 289 patients, so 40.8% patients in the overall population had tumors with AKT pathway alterations. So 30% PIK3CA, which I would say actually in some data is up to 40%, 5% AKT, 5% PTEN. 70% of patients in reality in this study had CDK4/6 usage. 50% had prior chemo. This was given in the curative setting. 18% had chemo in the metastatic setting. So this is the results from Capitello 291. If you compare capi fulvestrant to placebo fulvestrant, capi does look better, with a PFS improvement from 3.6 months to 7.2 months. In terms of AKT altered tumors, we see an improvement 3 months to 7 months. This is statistically significant. Now, you might ask that I showed you fulvestrant alone is probably not a great control arm, and that's just the way the studies are done, right? Don't you think an alpelisib fulvestrant would have been a better control, but that would never happen because they're made by competing companies. So Capitello 291 discussion, like I said, this is intermittent dosing schedule. Interestingly, patient-related outcomes are better. So delayed time to deterioration of quality of life, maintain other dimensions of quality of life, healthcare-related quality of life symptoms. Eligibility criteria, we must note that patients were allowed to have slightly higher A1C. Patients could not be on insulin. SOLAR-1 required patients 6.5 or less. INAVO required less than 6%. This is an interesting comparison of the drug toxicities that we see from these drugs that are targeting the PIK3CA mTOR pathway. So we've got everolimus from Bolero-2, which is the mTOR inhibitor. We've got alpelisib from SOLAR-1, and we've got capivasertib from Capitello-1. In terms of hyperglycemia, we can see that with everolimus, we had like 13% any grade, a lot of hyperglycemia with alpelisib, 64%, and grade 3 or more, 36%. And I can tell you this is an absolute problem. Patients hate it, can be very difficult to manage. Capivasertib looks much better, 16% any grade and only 2.3% grade 3 or higher. In terms of rash, I would say rash, my experience has been very similar. The data reports slightly more rash than alpelisib. I think clinically it's about the same. I use Claritin or antihistamine preventatively for all my patients on alpelisib or capi. Personally, I'm using a lot more capi because of some of the side effects. Stomatitis, a lot of stomatitis with everolimus. We use Dex mouthwash here twice a day with that. I don't personally use everolimus much, given we have so many other drugs that are now targeting that pathway. But I would say I've rarely seen stomatitis with capi. In a small number of patients, we use inert mouthwashes or Dex mouthwashes. Diarrhea, I would say, is a little worse with capi than alpelisib or everolimus, but I think we also are very comfortable managing diarrhea, so that doesn't tend to be as big of a problem as hyperglycemia. Okay, doing good on time. So hyperglycemia, let's take a minute to talk about that. So this is an on-target side effect of PIK3 inhibitor pathway. This is on target but undesirable. So the reason we get so much hyperglycemia is that the PIK3 inhibitor is involved in this GLUT4-mediated transport of glucose from the cell into the skeletal muscle, liver, or pancreas. So if that whole pathway gets blocked, then the glucose stays inside the cell, so we get additional uptake from the skeletal muscle, from liver or pancreas, which leads to hyperglycemia. So the package insert for all of these drugs asks for monitoring and optimal management. Okay, so where are we with treating HR-positive metastatic breast cancer beyond the PIK3CA inhibitors? What about CDK4/6 inhibitors? What about introducing a different or a alternative CDK4 inhibitor in this space? There is data for that as well. So if endocrine therapy resistant drives progression, but the disease is CDK4/6 pathway dependent, the idea would be you just switch the agent, because we know that different agents have different blockage of the CDK4 and CDK6, and the drugs look very much different, especially since the data that I've shown you, some have different overall survival, even though we can argue about the design of these trials, but there's a strong theory that these could be different drugs, and maybe ribo is better than palbo, and maybe abema is better than palbo. So what we have seen, though, is with PACE and Palmyra, if you continue the same CDK4/6 inhibitor and if you just alternate the endocrine partner, that is not helpful. So that's where this rationale had come into the clinical space, that what if we just swap out the endocrine therapy and the CDK4/6 inhibitor to see if that approach would work. So I have some data that I'm going to show you. So Maintain was the first trial in this space that was reported. This took men or women age 18 or older, ER/PR positive defined greater than 1% or more, metastatic breast cancer patients, progression on endocrine therapy and any CDK4/6 inhibitor, one or less chemotherapy patients. So these are not heavily chemo-treated patients, measurable, non-measurable, postmenopausal, pre were allowed as long as they had a GnRH agonist, so they were effectively postmenopausal. Patients were randomized 1-to-1 to ribo plus switch of endocrine therapy or placebo plus switch of endocrine therapy. So whatever they got in the first phase, the second CDK4/6 that they got was ribo, which means that there are a small number of patients, yes, they did go from ribo to ribo. So here's the breakdown on the previous CDK4/6 inhibitor usage. What we're going to see in these CDK4/6 after CDK4/6 trials is that most of the patients in the first line had palbo because that was the first drug on the market. So most of the patients, 86% had palbo, 13% had ribo, and very small number of patients had abema, as you can see. Previous CDK4/6 inhibitor in the metastatic setting, everybody had it, obviously based on the design of the study, and median duration of the CDK4/6, which I told you could be our new surrogate marker for endocrine sensitivity, was 11 to 23 months. So these were not like your rapid progressors progressing in 3 months. Here's the previous CDK. So those that had a duration less than 12 months was 35%, and over 12 months was 64%. So this is the results of the Maintain study. Ribo is the red arm and placebo is the blue arm, and you see that there is an improvement. If you switch from whatever they were on to ribo, there is an improvement with that approach. The PFS rate improved from 23% at 6 months to 41% at 6 months, and at 12 months, it improves from 7.4% to 24.6%. So here is the breakdown in terms of favoring of ribociclib. If you had previous palbo, it looks like a better improvement. If you had previous ribo, the forest plot, the hazard ratio does cross, the confidence interval does cross 1, but we have to recognize that this is a small number of patients. This is only 14 patients. Maybe it's a small subset, or maybe there's really no benefit because patients are going from ribo to ribo. This is very interesting. So if your patients have an ESR1 mutation, it does not look like there's any benefit in switching to a different CDK4/6 inhibitor. So what is the discussion? This is a phase 2 trial. It's not designed to answer the question specifically. I think it does raise some interesting concerns and it does give us some interesting ideas. Majority of patients did get the first line palbo, 87%. PFS benefit with fulvestrant plus ribo is limited to ESR1 wild type patient population. PIK3CA population, this is also a small population that is not reported in that forest plot, but there's no PFS improvement if you add ribo to fulvestrant. Okay, post-Monarch is another study that this was just reported out in ASCO of last year. And this is switching now. Last was switched to ribo. This is switched to abema. So this is very similar patient populations. Here, patients are randomized to abema plus fulvestrant to placebo plus fulvestrant, and these are the endpoints. So here's the data. Once again, the demographics. I'm going to focus on what patients got in the previous setting. So similar to what I showed you, majority of these patients were palbo treated. In this study, they were 60%. Ribo was the second most common used CDK4/6. This was 30%, probably because it was designed a little later. So now we have more ribo usage here in the first line. And then we have 8% of patients in the abema treatment group. Here's the prior CDK4/6 duration over 12 months. Again, most of them were over 12 months. 30% were under 12 months. And this is the duration of each individual CDK4/6 inhibitor. So what do we see here? We see a improvement once again with that switch to abema from a large cohort of heavily palbo-treated patients. So this raises a concern. If you have a patient that's done very good on palbo for a couple of years, you don't have a mutation, could you go over to abema? And I think this data is very interesting in that direction. What I want to point out here, which I think raised a lot of concern at ASCO when this was presented, was why are we seeing a 5.3-month PFS in fulvestrant? This is very unique. For so far, in a lot of the trials, I would say even clinically, we are seeing 2 to 4 months at most in the fulvestrant monotherapy arm. And this could be that these are these true second-line endocrine therapy, ER positive, endocrine sensitive patients. So we have controlled the group for a very sensitive patient population, and we have excluded all these sort of high-risk patients. So here are the subgroup analysis for this, where you're seeing the abema benefit. I would say if you have kind of a longer term, if you have a prior duration that's over 12 months, palbo once again looks like the greatest benefit is if you've got a palbo patient that's done really well for a couple of years and you move on to abema, there's benefit. Ribo, so I would tell you personally, I do switch if I need to, and I don't have any other good options or mutations. But I do have concerns about the ribo arm here crossing 1. Is that because the numbers are much smaller, right? 122 compared to 217, or is it because ribo is just a better drug than palbo? We don't know the answer to that. So here is the ESR1 information. So there is line crossage, whether there's ESR1 detected or PIK3CA detected. So there's really no consistent benefit one way or the other. So the interesting thing about this is an all-oral regimen. There was 30% of patients had prior ribo, 60%. Again, majority were palbo-treated patients. There's benefit regardless of ESR mutation detection or PIK3CA mutation detection. Obviously, there's a difference in biology of abema in terms of the 2-9, the 4 blockade ratio. Control arm with fulvestrant performed much better than expected. Patients were less heterogeneous, in my opinion. They were not allowed to have received chemotherapy or more than one line of endocrine therapy for advanced breast cancer. So I think this might be our last study before we wrap it up. This is the EMBER-3 study, and this was just reported at SABCS 2024. These were men and pre-postmenopausal women, prior therapy in the adjuvant. So these were patients that had recurrence within 12 months of completion, progression on first-line therapy. Patients were stratified to 3 groups. So this gets a little complicated. Group A is imlunestrant alone, which is an oral SERD. Group B is standard of care, so fulvestrant or exemestane. And group 3 is imlunestrant plus abema. Now, you might look at that and you say, once again, why are we seeing a fulvestrant monotherapy arm? Should this not be a doublet with like abema or something? But once again, that's how the trials are designed. So what are the primary endpoints? A versus B in ESR1 mutated patients, A versus B in all comers, and A versus C in all patients. And these are the key secondary endpoints. So in terms of things we want to call out here, this is the ESR mutation and PIK3 pathway mutation demographic. Here is the previous CDK4/6 usage that we have talked about. Once again, majority palbo patients, 60 to 70%, which has been pretty standard from post-monarch, 20 to 30% of ribo usage that I showed you, actually very similar to post-monarch, and a small number of patients with the abema treatment. So here are the results. So remember I showed you there's those sort of 3 groups. In the first group where we're comparing oral SERD imlunestrant to the standard therapy, which was the fulvestrant or endocrine therapy arm, imlunestrant looks better. That doesn't come as a surprise because we have seen that elacestrant is better than fulvestrant or endocrine therapy too. So 3.8 months versus 5.5 months. This is that second group where we had the imlunestrant this is imlunestrant versus standard therapy progression-free survival in all patients. So this is ESR1 mutated. This is all patients. What I want to show you is the combination versus imlunestrant alone. So when you compare SERD CDK4/6 versus SERD, the SERD CDK4/6 looks very good. So this gives us kind of another novel idea. If you've got patients that have had a CDK4/6, which is primarily palbo with AI or fulvestrant, something like this, a SERD abema approach could be a very interesting approach. And that PFS goes from 5.5 to 9.4 months, which in my opinion, in the second line setting is fantastic. So here's the breakdown in terms of visceral metastasis. There's benefit. Previous CDK4/6, I think if they've had it, that there's certainly benefit there. ESR1 mutation or PIK3CA mutation, there's benefit across whether there's a mutation present or absent. And there's a benefit in patients if there is a concurrent ESR1 mutation and PIK3 pathway mutation present. Because that is another sort of clinical rationale that if you have both mutations, we call it co-mutation, that could represent a very high-risk resistant patient group. So what do we learn from this EMBER-3 study? I think one critique, which I think is a fair critique, is that the standard of care arm with the 88% fulvestrant, it's probably not realistic right now because we're not using fulvestrant as a single line, as a monotherapy in the second line. Should that have been a BEMA? Should that have been a PI3K inhibitor in the PIK3CA mutated patients? I think it's important to note 60% of patients did have a prior CDK4/6, as I showed you, majority were palbo. And then future combinations, I think this is really where this field is going to move, is the combination of the SERDs with the CDK4/6 and the PIK3CA inhibitors. So this is a fantastic chart that one of my colleagues created that I borrowed with permission. And I think it does a really good job of summarizing where we are in that second line space. So maintain is that the CDK4/6 after CDK4/6 study, where the second CDK4/6 was ribo, if there's no mutations, the PFS is 5.2 months. If patients had a ESR1 mutation, there was no benefit, and if patients had a PIK3CA mutation, there's no benefit. We do not have any data from this trial on the co-mutated patients. Post Monarch, this is the CDK4/6 after CDK4/6, but the second CDK4/6 was the BEMA. There is a 6-month PFS in these patients as all comers. There's benefit in ESR1 mutated patients and benefit in PIK3CA mutations, but I would argue these are small subgroup analyses. So whether we make like clinical decisions based on that, I think that's sort of left up to the individual treating physician's discretion, but it's interesting signal nonetheless. Elacestrant, Emerald, I'm so sorry, with with ESR1 mutation, there is an improvement up to 8.6 months PFS, but please note the greatest benefit wasn't those that had the CDK4/6 inhibitor for over 12 months in the last setting. If in the co-mutated patients, the PFS shrinks down to 5.5 months. BYLieve study, we didn't have time to go over that today, but we know in the PIK3CA mutated patients, the PFS is 8 months. In the co-mutated patients, again, those that have ESR1 and PIK3CA, that shrinks down to 5.6 months. In Capitello 291 with patients with PIK3CA mutation, we have 5.5 months. We have not seen any data on ESR1 mutations or co-mutations from this study. With everolimus, this is one of the older studies, Alcina, overall PFS is 6.8 months, similar benefit with ESR1 mutation, and 3.4 months with PIK3CA mutated patients. So the conclusion, I would say in the first line, we have plenty of data that we should be using CDK4/6 inhibitor, and your endocrine backbone could be AI plus minus OFS for the young patients, depending on the right clinical setting based on what they've had in the past, whether they recurred on adjuvant disease or fulvestrant with a CDK4/6 inhibitor. There is the new triplet combination that's FDA approved here in the US, and that's for PIK3CA mutations and that very specific patient population I showed you. In the second line, I think the space is increasingly getting more complex. So for ESR1 mutation, we have data for elacestrant and FDA approval. We have data for imlunestrant that's not yet FDA approved. We have data for PIK3CA mutation with alpelisib. We have data for PIK3CA pathway alterations with capi fulvestrant that I showed you. We actually have data for BRCA mutations, germline and somatic with PARP inhibitors. We didn't go through that, but that's been presented by Nadine Tung. There is data that I showed you from 2 studies from Post Monarch and Maintain, and that's essentially CDK4/6 after CDK4/6. Majority of these were palbo in the first line, and we have seen data now for using ribo or abema in the second line. I guess there's still everolimus out there. I don't think most of us are using it. And then there's data on imlunestrant plus abema from EMBER-3 that I showed you. This is also not FDA approved. So I'm going to pause here, and I'll be happy to take any questions. I would also welcome any thoughts on those of you who treat breast cancer.
Thank you so much, Dr. Azka Ali, for this wonderful overview. Very well done and orchestrated. I think we have 5-6 minutes for Q&A. So, please feel free to unmute and ask questions, or if you would like to just, type in your question here, I'd be happy to relay it to Dr. Ali, or she can just respond. So, any questions from our audience?
Oh, role of ADC. Okay, that's a wonderful question. So, when I put this talk together, I guess it was very ambitious of me that I actually do have slides here in this space too. It ended up being over 100 slides, which I thought was cruel and unusual punishment for people to have to listen to that much information. Yeah, there's a huge role of ADC. Obviously, that's a separate talk in itself, in my opinion. I am planning to come back, I think around September is what we decided. But just to kind of, I guess, wrap it up in 1 minute or less, um, with antibody drug conjugates, we saw data with trastuzumab deruxtecan in HER2 low patients. So, like I briefly mentioned, the HER2 positive or negative for breast cancer, that's now a whole complex space now. So HER2 low is 1+ or 2+ with the negative fish, and now we have an even newer category called ultra low. So these are patients that have less than 10% or equal to 10% membrane staining. So we had seen data from Destiny Breast 04 that patients that were HER2 low, so these are patients that would not be eligible to get a HER2 targeted antibody drug conjugate, they derived quite a bit of benefit, like a PFS of like 7 to 8 month improvement and an overall survival advantage. So TDXT was approved in all HER2 low patients after 1 line of chemotherapy. Now we have seen data from Destiny Breast 06, and these are patients that are post-endocrine therapy, pre-chemotherapy, and TDXT was compared to chemotherapy head-to-head analysis, where majority of the patients received capecitabine as their chemotherapy. So 60% cape, I think it was 25% Abraxane, and 10% paclitaxel, something like that. And TDXT was much better. It was better for patients that had a quick progression. It's better for patients that have a delayed progression. It's better for patients that have visceral mets. It's better for patients that have lung mets, liver mets. So it looks much better than chemotherapy. I would say, to your point, ADC would be like post what we just talked about. So we are talking about endocrine sensitive disease today. I would say when your disease is resistant, when patients are progressing on this second line we just reviewed, second line endocrine therapy, or patients are thought to be endocrine refractory, that's when I would incorporate ADCs or chemotherapy.
All right. Well, wonderful. Any other questions, please type. I think there are a few folks, Dr. Azka, who would like to actually contact you about research opportunities. So I think, Dr. Azka has shared her email there, alia22@ccf.org. So please feel free to reach out to her. Are there any other questions for our speaker?
Chemo is out in hormone positive visceral crisis. Do you mean so you're talking about, I think, phase 2 right choice, which I didn't have time to review today. So that is a phase 2 study looking at CDK4/6 upfront in visceral crisis. So historically we have had patients with visceral crisis that have admitted to the hospital with like liver mets and high LFTs, and we have always kind of thought of doing chemotherapy. I would say clinically sometimes we still do chemotherapy because these are CDK4/6 inhibitors are oral biologics, so they can be difficult to get readily. But if you see this patient in clinic and the patient is extremely stable with like slightly rising LFTs, yeah, I would do actually CDK4/6 inhibitor. It looks like upfront CDK4/6 inhibitor for metastatic HR positive HER2 negative breast cancer, even with visceral crisis, is better. It's better in terms of response rate, duration of response. Obviously, it's better in terms of toxicity. Okay, just want to make sure we're not missing anything in the comments.
Yeah, I don't see any other questions coming in. Dr. Azka, this was a wonderful talk. Thank you for everyone for joining in. This was a very well-attended lecture, and I think we can close the session.
Thank you. Thank you for having me, everyone.